Then I will discuss the pharmacokinetics of phenytoin. Phenytoin is used for partial or generalized seizure, and it's probably the most commonly used anti-epilepsy agents. I will not spend a lot of time on the pharmacology of the drug, so I will go over some of the slides a little bit faster than normal. Phenytoin is available as acid or sodium salt. The sodium salt have 92% phenytoin acid. So when capsule or IV dosage are used, we need to account for that, because what we measure in the plasma is phenytoin acid. So we need to consider that S in this dosage forms, capsule or IV, is 0.92. And again, it's available as IV, tablet, capsule, and suspension at many dosage forms, and also at many different amounts. It is completely absorbed, and when the salt is used, some people use 0.91 as the S, and some people use 0.92. F is 100. IM dose is contraindicated because of erratic absorption and very painful injection when it's given IM. Distribution: phenytoin distributes into body fluids freely, and also into the CSF and breast milk. It is 90% bound to albumin, and this is very significant when we look at the patient who have low albumin level, because they will have more percentage of the drug, of the total drug in the body, as free fraction. And in these cases, if the patient albumin is less than 4.4, we will need to know or find out the effect of the measured total phenytoin in this patient, because it's going to be more than the effect of the measured total phenytoin in another patient with a normal albumin. And we call this adjusted plasma concentration for normal albumin, which means we adjusting the measured total phenytoin according to the measured low albumin. And in a simple way, you can look at it as if phenytoin is measured in a patient as of 10 total phenytoin concentration, and the patient have half the normal albumin concentration, then the effect of this 10 total phenytoin concentration may equal to like 20, the effect of 20 if the patient had a normal albumin. To know what's the effect of the current measured total phenytoin, we convert it to adjusted total phenytoin using this equation here. However, this equation is used in a patient with normal kidney function. If the patient is having uremia or on dialysis, they're gonna even have more free phenytoin. So we're gonna need to use a different equation, which add 0.48 to the equation, as you see right here in the bottom, and this is the adjusted plasma concentration of phenytoin in a patient with low albumin and with uremia or on dialysis. And again, we have to do that because these patients will have higher percentage of free fraction of phenytoin. In a normal patient, you will have 10% free, 90% bound. In patient with uremia or albuminemia, you may have 20% or 30% free fraction. And in these cases, sometimes clinician will just go ahead and order free phenytoin. And when free phenytoin is ordered, the lab normally report total and free. And the reason for that is really is the fact that some investigator found that these equations are not really very accurate. But in some patients it was used with reasonable degree of acceptance. The volume of distribution for phenytoin is about 0.65 liter per kilogram, and we use ideal body weight. Except for obese individual, we use adjusted body weight. Neonates have higher volume of distribution, and obese individual, we will need to use the equation in the slides here, which account for the actual body weight being higher than the ideal body weight. So we multiply the difference between actual and ideal by 1.3 and add this number to the ideal body weight, then multiply this dosing weight by 0.65 to get the volume of distribution. So we need to adjust plasma level for normal albumin if the patient have low albumin and kidney function, and we need to use a different equation if the patient is having low albumin and also on dialysis or having uremia. The drug is metabolized and cleared via conjugation that follow the cytochrome P450 metabolism. Hydroxylation followed by glucuronidation. And what's important about phenytoin to know is that it follows Michaelis-Menten kinetics, which is capacity limited metabolism. And the pharmacokinetic parameter for capacity limited metabolism are Vmax and Km. Vmax is the maximum rate of metabolism, and Km is the plasma concentration where the rate of metabolism is about half maximum. The clearance equation, as indicated here, relate clearance to the plasma concentration, which means that clearance is dependent on the current amount of drug in the body or the current plasma concentration in the body. And this is different than first order kinetics. In first order kinetics, clearance is independent of the amount of drug in the body. It is dependent on the, or clearance is like percentage of drug removed, i.e. in half-life, half of the amount in the body are removed. In case of phenytoin, this is not the case. It's a zero order, which means that the concept of half-life is not here. The half-life dependent on the plasma concentration, because drug is eliminated in an amount per time, not as percentage per time. In first order, you eliminate 50% in half-life. In zero order, you eliminate X amount per time, not X percentage. Okay? And this graph here is from the required textbook, where it indicate or represent the plasma level following different the administration of different daily doses of phenytoin. And as you see, when the dose is increased, the plasma level is increased in more than proportional to the dose. The graph here represents 4 patients receiving different dosage, and the measured blood level in these 4 patients are represented by each line here. And initially you will see that the drug follow first order kinetics, then at higher doses above like 100 milligram per day, which is above what we normally give to patient, the drug kinetics follow Michaelis-Menten kinetics. You saturate the enzyme in the body when you give doses above the Vmax, and in this case the level accumulate. And that's why when we increase the dose by like 15%, we get a level that is about 50% higher, not 15% higher than what you get from previous dose. To estimate plasma concentration for any patients, you need to know what is the Km and Vm and the current dose, and you use this equation here, CSS average, to predict what the level may be. If the patient is naive and did not receive phenytoin before, we use Km and Vm of the population. If the patient receives the drug and you have levels, then you try to use this level to estimate Vmax or Km, and you use this value as the patient value, which are more appropriate than the population value. These are the population value for Km and Vmax, and for adult the Km is 4.3 milligram per liter and Vmax is 4.4 milligram per day. Now, people from different ethnic backgrounds or researchers in different countries identified different Km and Vm or Vmax, and these need to be taken into consideration. Some reported Km as high as 6 in adult, not 4.3. The half-life again is concentration dependent, so we don't use half-life in phenytoin, we use T90, and T90 is the time required to achieve about 90% of steady state concentration. So the steady state is achieved not in 4 to 5 half-life, because half-life concept is just does not exist here. Okay, we also use different time equation to calculate the time that is required for a concentration C1 to decline to a concentration C2, and we call this T difference, T diff, and this is different than the equations that we normally use in first order kinetic. Which is used to be in first order kinetic T difference equal to ln C1 over C2 divided by Ke. Here we don't have this Ke, or we don't use this equation. The T90 equation is shown here, and remember that the value in the denominator is square root. This is the time to reach 90% of steady state, and assuming the use of these units for VD, km, Vmax, and dose. This is the equation to estimate the time in days a concentration 1 will be declined to a concentration C2. And again, it's important to use the units correctly. Of course, this is assuming that there is no doses would be given between the measuring of C1 and C2, which means if you have a level C1 and you just leave the patient without a dose, and you want to know when this C1 will decline, if the patient did not receive any doses, when this level C1 would be declining to a level of C2. And we use this equation normally if we have a patient who has a high level like phenytoin level of 35, and the patient is showing sign and symptom of toxicity. So we try to estimate how long we need to keep the patient off medication until this level of 35 become 10 or so within the therapeutic range, so we can start therapy again if we would start therapy. The therapeutic window for phenytoin for most patients, as we said, is 10 to 20 milligram per liter, and sometimes you will see a patient who may need 22 or 24 or even 25 to control seizure, but the most commonly recommended range is 10 to 20. And considering that 10% of the total phenytoin level is free from binding to plasma protein or albumin, then the serum phenytoin, serum free phenytoin level should be 1 to 2 as a therapeutic window or therapeutic goal. We normally measure the trough level before morning dose, and based on that trough level we start learning about the patient and correlate this level with efficacy or toxicity, and also use it to calculate some of the patient parameters if we need to. So total phenytoin level is 10 to 20, free phenytoin 1 to 2, and we measure trough. Initial dosage recommendation in most cases are started at milligram per kilogram doses, and this is designed at or recommended at 4 to 5 milligram per kilogram to achieve a low level of like 10 or so milligram per liter of phenytoin. However, we can utilize pharmacokinetic principles of learning about or predicting the volume of distribution, and design a dose that will achieve a specific level of 10, 12, 15 or so by multiplying the volume of distribution of the population that the patient belongs to, multiplying that volume of distribution by the concentration that we desire. The lowest effective dose is normally given, and this is the commonly given doses. In adult, we give about 15 milligram per kilogram loading dose if it is needed, and some people shy away from giving loading dose now on phenytoin, but we may need it if the patient is admitted to the hospital and you're starting therapy, or if you want to give IV medication to reach the levels that you want very quick. Maintenance dose in adult is 5 milligram per kilogram per day, and as you notice from the table, children require higher doses of phenytoin in milligram per kilogram, probably because of increased metabolism. If you give IV loading dose, you should not exceed 50 milligram per minute to avoid dose-related EKG changes or hypotension or cardiovascular side effects such as bradycardia, hypotension, and EKG problems. In pharmacokinetic approach, you need actual body weight and you compare it with ideal body weight, and you need to decide if you gonna use ideal body weight or adjusted body weight. We use adjusted body weight for obese patient, and some people use it for obese when the weight or the actual weight is about 40% higher than the ideal weight, body weight. The VD in adult is about 0.65 liter per kilogram, again dosing weight. These are the population KM and Vmax. Your goal should be between 10 and 20. We start at 10. So VD is 0.65 times dosing weight. Loading dose is the concentration times VD divided by S and F. Population Vmax is calculated in km for the patient from the tables that we provided in previous slides. Then the maintenance dose may be designed according to the equation provided here. And you can give the daily dose in divided doses 2 to 3 times a day. If the patient is receiving therapy and steady state is achieved and we have a trough level, then we can use this level to adjust the dose if needed. So if the patient blood level is not within the therapeutic range and we want the level to be within the therapeutic range, then we may need to adjust the dose. In this case, you need to know the time of the last dose, and we need to be sure that the level is a trough level, and you need to correlate level with response. If the patient is toxic, you want to lower the level, and you want to know how much you want to lower the level to or by. And most of the time when we adjust dose, we don't really give a loading dose. We just collect information and calculate the dose needed to achieve a desirable level. Now, if you have one level, then you can assume that the patient is having a population KM value. If an adult, then the KM is like 4.3. Okay, if children, we assume it's 6.5. Then we plug this Km into the Vmax equation to calculate the Vmax based on this Km of the population and the current dose and the current blood level that is achieved by the current dose. Once we know the Vmax for the patient and we use the population Km, then we calculate the maintenance dose that is needed to achieve the desired concentration that we want to have. So if you have a level of 15, you plug it in step 2, and if you want level of 18, you use this in equation in step 3. So adjusting dosage regimen is a 3-step process. First step, calculate population Km from based on patient population and publish data on that patient population, and we just pick it from the list in step 1 here. Step 2, calculate Vmax. Step 3, use this Km and Vmax to calculate the new dose. There is another process if you have 2 levels. If you have 2 levels that are representing two different steady states achieved with two different dosage regimen. Let's say you have the patient received 300 milligram and the level was 5, and the patient received 330 milligram and the level is 8, and now you want to achieve a level of 12. Then you can use these two doses and these two levels that are measured to estimate better Km and Vmax for that patient. Then use this Vmax and Km to calculate a new dosage regimen that you may need to achieve the level of 12 that you want. In this case, first step, you calculate Km for the patient from the equation provided here. So in this case, we don't use the population Km. We try to estimate a better Km for that patient based on the two doses that the patient received and the two levels that the patient expressed. Then we use this Km to estimate or calculate Vmax and new maintenance dose as previously described in steps above in A. Also, dosing graphs and tables exist, and I made a table myself and I'll show it to you in a little bit. This is a graph to estimate Km or Vmax with different degree of probability according to measured levels. This is not really used clinically often, just because of lack of accuracy in it when you use graphic methods. These are different equations that also extracted from the slides that we have. This is a dosing table that I designed a while back, and basically let me show you this in a PDF file where I can highlight some things. I designed this to use it for initial dosage recommendation as well as adjusting dosage. So for initial dosage, you need the patient dosing weight, and we put it here. This is initial dosage. Based on the patient weight in this line here, or in pound or kilogram, the loading dose is in this row here, and the maintenance dose is here. And this is designed at 4.5 milligram per kilogram doses, okay, to achieve level of like 10 or so. If you have a level, one level at steady state, then we are doing adjusting the dose based on measured steady state serum level. If we use population Km of 4.3 milligram per liter, then we start by step 1 here, the measured phenytoin concentration, and we pick number from here. What is the measured phenytoin? Based on the row here. So let's say the measured phenytoin is 30 as step 1 here. Okay? And we want a level of 15. So this is the goal here. Step 2 goal, you pick from the green line here, 15. So the current level is 30, and we want a level of 15. In this case, you go from the 30 down and the 15 to the right, and you find that you need to cut the dose by 11%, minus 11%. That's what you would do. So if the patient is getting 330 milligram and the level is 30, you will cut it by 11%, so you will cut it by 30 or so. That's 10% is 30, 11% maybe 33, 35, 33. So you will need about 300 milligram to achieve a level of 15. This also can help you decide what happens if you cut the dose by 20%. If you cut the dose by 20%, the level of 30 will become 10. Okay? And thus I designed this based on the equations provided below to give me just a quick idea of what I can recommend. If you go down in this sheet here, or the slides, I have a table here to adjust the measured level, so based on the patient albumin. So if you have a level of 7 here, this is the measured level in this column in red, in this row in red, and on the column on the left side is the serum albumin, and in the middle in black is the corrected phenytoin level if the patient albumin is normal. If the patient level is 7 and the serum albumin is 1, then this is going to have the impact of 23. If the serum level is 7 and the patient is having albumin of 1 and also uremic, then this level of 7 going to have the impact of level of 35.3. The adjusted plasma concentration in this patient will be 35.3, which means this patient will be toxic and overdosed and show sign and symptom of toxicity as if he or she had a total plasma level of 35. And that's why we need to adjust plasma level according to albumin, and we normally do this when the albumin level falls below 4. Some people recommend to use this equation when it falls below 3, okay, as having real hypoalbuminemia. Okay, spend some time on this chart. You will find that it is very helpful, and you may be able to use it. This is another chart that I developed in my patient, and based on the value I got, I was able to make this equation here, which worked well for me. The percentage change in dose equal to the desired concentration time concentration plus 6 divided by current concentration time desired concentration plus 6. And based on this percentage change, I was able to derive this table here. So if you have a level of 10 and you want a level of 15, you go down here to 15. Sorry, you start from here. If you have level of 10 here in the column, and if you want a level of 15, you go to the right and you find that you increase the dose by 14%. Okay, so in the left column, in the column here is the current concentration where you start with, and on the right in red, the row here is the desired concentration in red, and you go down to find the percentage change in current dose, which I call the H factor. And this table was derived from this equation here that I made up, and in this equation I was able to use the factor of 6 here, and that was the KM actually in this patient population. So if your patient population or you find that in your state or country, or this is for adult, for pediatric you may use higher number, or if you find KM in your population higher than 6, you may use that. And over time you will enhance the table or the equation based on your population. I presented this in American Association of Colleges of Pharmacy annual meeting in 2005, and several neurologists used it and told me it was working well for them. You monitor patient response, serum blood level, trough, and so on. We talked about this. You always assess compliance. So, patient monitoring, you monitor level, efficacy, adverse effect, and drug interaction. I'm going to go over this very quick. Blood level, you monitor trough. You want to be sure the patient is compliant with medication, otherwise, and dose. Otherwise, your adjustment will not be valid. Your calculation of patient parameter will not be valid if the patient is not taking the drug as you think he or she is. You monitor the efficacy of the drug, the frequency of seizure. You ask the patient about adverse effects, if they have any, and you want to be sure that to classify the adverse effect. Is it dose-related adverse effect or dose unrelated? Stevens-Johnson syndrome, for example, is not dose-related adverse effect of phenytoin. Very bad dermatologic reactions. You want to counsel the patient on what to expect and what to do if they experience this adverse effect, the rash, or if it is CNS side effects, and what they should do about that. And giving the patient information sheets are very valuable. That tool that I found very helpful for the patients in neurology clinic or coming to the epilepsy clinic. You also monitor adverse effect as we talked, and you try to find out if it is dose related or non-concentration related adverse effect. And I have a list here. And again, there is infusion related adverse effect, as I mentioned before, and this is related to the fact that phenytoin is dissolved in glycol, and that is the one that causes side effects, the ingredient or the chemical, such as cardiovascular abnormalities. And that's why you want to infuse the drug very slowly, at rate of less than 1 to 3 milligram per kilogram per minute for neonate and infants or children, and less than 50 milligram per minute for adults. With regard to drug interaction, you know this from pharmacology, that several drugs interact with phenytoin, and phenytoin also induces the metabolism of many agents. Enzyme inducers can increase phenytoin metabolism, and you have a list of these drugs there. Also, enzyme inhibitor or inducer can cause adverse effect or can cause lack of efficacy to phenytoin therapy. Another potential drug interaction happen when you give a drug that displaces phenytoin from plasma protein. In this case, it will free more of phenytoin into the blood and will cause higher toxicity even at normal total therapeutic level of phenytoin. Some of these drugs are listed here, and this include salicylate or valproic acid. And antacid may decrease the absorption of phenytoin. Phenytoin was reported to adhere to tube feeding or to the tubes, or interact or bind to some of the ingredient in the enteral feeding, and this led some investigator to assume that this interaction led to lower plasma level of phenytoin. Other study questions this hypothesis, but it's something to consider when you give a patient enteral feeding. You need to measure the level closely first and see if there is an interaction or no interaction. Phenytoin phenobarb is complex because the drug level may increase or decrease based on the timing of the interaction, and some clinicians reported that the level is initially decreased, then later on the metabolism is initially decreased, then later on is increased. So you want to look at this carefully. This is a list from the textbook on some of the drugs that interact with phenytoin. You also monitor for the possibility of drug-disease interaction. We know that in cirrhosis or renal failure, the clearance of phenytoin is lower than normal. In burn patient, it's higher than normal because of the hypermetabolic stage. In dialysis, a significant amount is removed by hemodialysis or peritoneal dialysis. So you may need to give a dose after dialysis to patients to minimize relapse or seizure occurrence. And also different population have different clearance ability. You want to pay attention to that. And this population include pediatrics, geriatric, pregnancy, and also obese individual. Here is a phenytoin case. If you have 25 years old, 6'5", with seizure, and you want to start phenytoin to achieve a level of 15. In this case, you don't have a level. The patient did not get a drug before, so you don't know what the patient is like. So you use the population value. The ideal body weight in this patient is about 85, similar to actual. So we'll use the ideal body weight to calculate volume of distribution, and we multiply the weight of the patient by 0.65, and we multiply this volume of distribution by desired concentration of 15, and divided by the salt of 0.92, and you get about 900 milligram per day as a loading one time as a loading dose. And you want to give it, if you're going to give it IV, you infuse it at rate less than 50 milligram per minute. To calculate the maintenance dose, you use population Vmax of 7.4 and Km of 4.3. You calculate Vmax in milligram per day, and you use this equation here to calculate maintenance dose. Vmax 629, Km is 4.3, and you end up with a dose of 531 milligram per day. Now, if this patient receives 500 or 600, you can predict what would be the level according to the population Vmax and Km. And the reason I have this here, because you will probably wonder, can I round the 530 milligrams that we estimated before in the slides before that? Can we round this to 500 or to 600? In order for you to do that, you need to have an idea what level you may get. by 500 or 600, and you use this equation here to predict the level. And you're going to use Km and Vmax of the population and the dose of 500 or 600. Okay, this is Vmax, this is Km for the population, and this is the S and F. A dose of 500 will produce a level of 11.7. A dose of 600 will produce a level of 30. So you will definitely avoid 600. You may use 500. Okay. Another alternative approach is to give 300 in the morning and 230 in the evening, and that will be 530. I would personally start on maybe 500 in that patient. A question here is, when would you think steady state will be achieved? And we can use the T90 equation to estimate when would the level be achieved. If you use the equation here for a 500 milligram dose, you will see that the patient will achieve T90 if 500 milligram per day was given in a shorter time than if 600 milligram per day dose is given. And this is different than the first order kinetics. First order kinetic, you will achieve T90 or steady state or 4 times of steady state exactly at the same time, regardless of the amount of dose that is given. This is very significant. You need to be aware of that. T90 will be 12 days if a dose of 5 series given, will be shorter if a lower dose is given. And you practice on using this equation to see how different value you will get using different doses. Another case, if the patient that we talk about early received 130 milligram TID and a level at steady state was 8, then what is the most likely Vmax in that patient? Since we have one level only, we will use Km of the population. If we have 2 levels, we will calculate Km based on the knowledge of the 2 level and the 2 doses. But now we only have 1 level, so we're gonna use Km of the population, and we will use that to calculate patient Vmax, then answer the question of what dose may produce level of 12. Now remember, the level is 8 now. You cannot increase the dose by 50% to get a level increased by 50% from 8 to 12. You will be making a big mistake. The level probably will be more than double if you increase the dose by 50%. To illustrate this, we're gonna do the calculation. The daily dose is 390 milligram per day. Okay. The Vmax for this patient using Km of 4.3 will be 550, 1.7 milligram per day. The new maintenance dose using the equation that appear here will be 441.5. So we went from 390 to 42 to increase the level by 50%. So we increase the dose by 50 milligram to get a level that is higher 50%. If you divide 50 milligram over current dose of 390, you will see that this is less than 50%. And even so, you would achieve 50% increase in the level. Okay. Now I will leave it for you to practice using this case to find out what dosage change you may recommend using my table. And let me show you what I would do. This current dose is 390, produce a level of 8. Now we want level of 12, so we want to increase the level by 50%. So the 390 using this, let's say, let me open this table here. So this is the current concentration in the column here, and we have 8, and we want to increase it to 12. So this 8, we go to the right here to a level of, we have here 12.5, so we will increase the dose by about 18% to get level of 12.5. So if you want level of 12, maybe increase it by 16% or 17%. So what's 16% of the current level dose of 390? I will just multiply here using this calculator. 390 times 16, oh, clear. 390 times 16 will give clear 390 times 0.16. I will increase it by 60 milligram per day, so I'll go to 450. That's my quick estimation. Another way to look at it is that to increase it by 16% is close to 15% maybe, so I will look at it this way. Here is my case. I went from 390 to 440, so I increased the dose by 50 milligram per day. If the dose is 400, not 390, then multiply it by 15%, that will give me 60 milligram extra. 60 over 390 give me 450. That's an approximate number that I can come up with. Okay. Now if we have two levels, we can use the equations that we addressed before to estimate Km, then Vmax, then the new maintenance dose for that patient, which would be more accurate than using Km of the population. That's it for phenytoin. Thank you very much.